Good afternoon, everybody. This is Judy Solomon from the Center on Budget and Policy Priorities, and I'm very pleased to welcome you to our first Connecting the Dots webinar today on supportive housing and healthcare. I'm going to turn it over shortly to Peggy Bailey, who's heading up our new Connecting the Dots project, and she'll explain to you the exciting work we're taking on there. But I personally am happy to welcome you on behalf of the health team, where we have joined with our stellar housing team to think about how we can deliver services in ways that meet the needs of whole people. The first step we had in launching this project was to overcome our own silos that we had between our health and housing teams, and we've all benefited so much from understanding each other's work. As health people, and I know we have a mix of health people and housing people on this call, we know we all are increasingly focusing on the social determinants of health, looking beyond healthcare services themselves, and safe and stable and affordable housing is obviously a key ingredient of those social determinants. So today we're going to home in on supportive housing. We're going to do the agenda, look at the agenda. We're going to look at supportive housing, which couples affordable housing with other services, including healthcare. And Aaron Doler from our housing team is going to start us off with some background on supportive housing, and then he's going to talk about the evidence for supportive housing, including the impact on healthcare costs. He'll then discuss ways that we can bring supportive housing to scale, focusing on the need for more rental assistance. And then he will turn it over to Hannah Katch, a senior policy analyst on the health team, who's going to talk about the role of Medicaid in the provision of supportive housing. We'll then take questions, which you can submit throughout the webinar. Don't wait till the end, through the chat box on your screen. We'll be compiling the questions throughout and want to be ready to go with them as soon as we finish the presentation. You should all know also that we're recording this, and the recording will be available on the Connecting the Dots website after the presentation. So we're going to get started now, and I'm going to turn it over to Peggy Bailey, who's going to talk about Connecting the Dots.
Thanks, Judy. So as Judy said, this is our first webinar of the Connecting the Dots Bridging Systems for Better Health project that we have here at CBPP. It's exciting because as the Affordable Care Act passed, we started working on how we can increase insurance eligibility and enrollment for people. And now that we're reaching more people are enrolled in insurance, and we're reaching more people that way, there's an importance to make sure that the benefits that they have are also included in their insurance, and in this case, Medicaid. And along with that, we're starting to serve people with more complex needs, and that is where we're starting to link in the social determinants of health. Of course, for decades, we've been talking about social determinants of health, but because of the Affordable Care Act and the goals that are related to it, and payment reform models that are happening across the country where providers are being paid for outcomes and not just in a widget fee-for-service-based system, we need to, those social determinants of health are particularly important to achieve those outcomes so that people get paid to do what they're doing and can meet the goals of the Affordable Care Act. So in doing that, though, the health system can't do it alone. And in this case, we're talking about the need to partner with housing, that there are things that the housing system can definitely do to help serve people better in housing and link people to housing, make sure people can stay in their housing longer. But there's a need to include the housing system to make sure that housing is affordable and of high quality, so that people so that the housing and services work together and people have high quality lives. So here at the center, our work is really, the great part about being able to work on this project at the center, as Judy mentioned, is the ability to work across our teams. We have the healthcare team that Judy heads up, the housing team, We also are working closely with our food assistance and welfare benefits teams to make sure that we're bringing the expertise of each system to the table as we think about how to improve policy for people with complex needs. And who are we connecting the dots for? So in this initial piece of the work, we're focused on people with behavioral health needs, so the mental health population, and people with substance use disorders, and how can we better integrate their housing? How can healthcare policy better help them access housing, better integrate their primary and behavioral health care, and impact their health while they're involved with the correction system? So not only when they're exiting the correction system, but what can healthcare policy do to help them throughout their involvement with the correction system to make sure that we can reduce recidivism rates and make sure people are connected to health? So because of this focus, one of our first projects was to look at supportive housing. There's general knowledge about supportive housing being effective, but what does that mean? What exactly do we know about supportive housing, its impact on health, its impact on housing stability, and costs throughout the public system, and that's what the paper that Erin is going to line out talks about. We wanted to also communicate the effectiveness of supportive housing outside of the housing and homelessness community to the other public systems that supportive housing can impact, whether that's health costs, recidivism rates in the correction system, or helping population health better. What we wanted to do in this project is clarify what we know, what are the knowledge gaps, and what policy directions we need to implement because of this evidence around supportive housing. So with that, I'm going to pass it off to Erin to talk about our supportive housing work.
Thanks, Peggy. As Peggy said, we published a paper on this that covered those topics of sort of what the supportive housing field looks like, the evidence and policy recommendations, and there will be a link to that paper at the end. And so I'm going to go over some of the key points of the paper, but also, as the focus of this webinar, dive a little deeper into the evidence on how supportive housing affects health and healthcare. But let's start with a definition so we're all on the same page. This was the most succinct I could get it to, that supportive housing provides affordable housing coupled with intensive, coordinated, supportive services for people who have difficulty maintaining stable housing without services. So I want to break that apart very quickly. The housing has to be affordable, of course, and we'll talk about how we make housing affordable through federal and state policy. But supportive housing, there are lots of ways that housing and services can be integrated, and this Connecting the Dots project generally will be thinking about many of those, but supportive housing is pretty specific. The services are much more intensive and far more coordinated than many other models of housing and services. And supportive housing in particular is for people who, without it, but for supportive housing, would not have stable housing. So that's very important because that's a much smaller population than everyone that might benefit from having services or healthcare integrated in their housing. It's a very specific population that wouldn't maintain stable housing otherwise. So who are those people? It's a broad group, but generally they fall into some categories, or at least there's some trends. Generally, many people who receive and need supportive housing have severe and persistent mental illness, substance use disorders, often both, or chronic physical illness. Many people that need and receive supportive housing have all three of these issues, and so it's a very high needs group and can be a very expensive group for the healthcare system. Because they have a hard time maintaining housing without affordable housing and services, they're often homeless. That's where much of supportive housing got its start, is in the homelessness world. But housing problems also end up in other places. They might be in jails or prisons right now, or maybe institutionalized in healthcare system, or in extremely poor quality housing. The housing problem could manifest itself in different ways, but often they are living on the streets or in shelters. Due to the high healthcare needs, this group also often are frequent users of emergency healthcare, healthcare institutions, and inpatient hospitalizations, both due to untreated or at least not well managed mental illness, physical illness, but also sometimes these institutions and emergency rooms, emergency departments are also used as de facto housing to try to get out of the elements. But I think it's also important that some of this group are not receiving any care or barely receiving care. And so they may be at risk of becoming frequent users of the healthcare system, but are not currently. But if the situation goes on where they're living without housing or adequate care, they may become frequent users of these systems in the future. So I'm going to go quickly into the key elements, what we see as the key elements of supportive housing. I talked about affordable housing. Generally, tenants pay around 30% of their income towards rent. Now, what that really means is that the housing, there has to be rental assistance, or almost always there has to be rental assistance attached to the housing. Building a building, usually people in supportive housing have extremely low incomes, often on SSI. Simply building housing, even if it has a low rent, is usually not affordable to this group. And so there needs to be assistance to fill the gap between rental assistance, to fill the gap between their income and even the cost of basic maintenance of most units. So it's affordable housing, almost always coupled with rental assistance. Supportive services are, of course, extremely important, and supportive services and supportive housing usually look specific to supportive housing. They're first and foremost housing oriented. The main goal is to keep people in housing, so they provide tenancy supports. That looks like help understanding a lease, help mediating between neighbors, helping people maintain their unit, whatever it is that might be a barrier to them maintaining stable housing in the future. The supportive services provide that. But they're also multidisciplinary, meaning that most supportive housing also provides some sort of, say, nursing care or behavioral health care, whether that's in the unit or if there's a case manager that connects people to those services in the community. It's almost always integrated with multidisciplinary approach. And finally, services are voluntary but assertive, in that tenants have choice and direction over the services they receive. But if someone, this is a question you often get a lot with supportive housing, if they're voluntary, how do you actually make this work? How do you keep people in their unit? Service providers keep going back even if someone is currently not engaging in services, and that has been shown to be very effective. It's important to say that supportive housing is integrated into the community. People in supportive housing have access to amenities. It's not segregated housing. And so that largely differentiates it from a segregated, say, healthcare institution or nursing home. And related to the voluntary but assertive supportive services, there's a strong emphasis on choice. Choice of housing, where you want to live, choice of service, goals that you meet with your service provider. There's a strong emphasis on choice. And finally, but very importantly, supportive housing has low barriers to entry. People don't have to meet certain treatment benchmarks, say, going through a certain type of treatment before they can get into the housing, nor is there significant screening criteria. If there were large barriers to entry, many of the people that supportive housing aims to help would be unable to access it due to, say, a criminal record or a history of bad credit, or simply because we're trying to get them into supportive housing in order to provide the treatment, and doing it beforehand can be difficult. So those are the main building blocks that define supportive housing and differentiate it from other housing and service models that you might see. So let's now go into the evidence. There's very strong evidence on housing stability. Supportive housing, in the way that I just described, keeps a vast majority of the people that enter it in supportive housing over the long term, or at least until the studies end. The between 75% and 90%, possibly higher, of people that enter supportive housing stay there successfully. The differences may be due to the clients in the study. Also, it seems that more experienced service providers can inch up that retention rate. So that's the strongest evidence. There's a lot of evidence showing that supportive housing is very effective at maintaining housing stability. But on the healthcare side, because that's really the goal of this webinar, there's less research on how supportive housing affects health. But one of the areas where there's pretty good research is how supportive housing affects people with HIV and AIDS. So people with HIV and AIDS that were homeless or unstably housed in other ways before entering supportive housing, it seems there's pretty good research that shows that supportive housing can reduce mortality rates, reduce risky behaviors, and improve viral load levels. So one of the best studies used a mixed criteria of they were measuring both mortality rates and an intact immune system, and they found that there was in supportive housing, the group in supportive housing was 63% more likely to be alive at the end of the study and have an intact immune system. So that's really a pretty large effect. Now, there's less strong evidence, mostly just because there's not as many studies out there, that supportive housing at least works as well as other treatments in the community for substance use disorders and might work better. There's not a lot of studies out there that really hone in on supportive housing as a substance use treatment, but the ones that do, it either works as well or works better than other treatments available in the community. And then there's promising evidence. There's only a few studies out there, but they seem to be quite positive that supportive housing can keep frail seniors who might end up in nursing homes, can sort of prolong that time to moving into a nursing home, so it can help them stay housed in the community. Helping families with high needs with mental illness or other needs keep their children out of the child welfare system. And there's a couple of studies that have found that supportive housing can help people successfully exit the criminal justice system, people that might be likely to recidivize or to become homeless after exiting, people with mental illness, sort of a similar group. There isn't a lot of research on that, but the research that does exist is promising. But importantly, we really need better research on how supportive housing affects health outcomes directly. That's partially due to just a lack of research, and we hope that more researchers will take that on, but it's also partially due to the design of the research. A lot of supportive housing research doesn't even track health outcomes, and the research that does focuses on the housing stability outcome and then sort of just tacks on a tracking of health outcomes. And so it's not specifically designed the studies aren't specifically designed to track or measure health outcomes accurately. So there's a lot of sort of data quality issues as well in this area. So that's really an area that we need to know more about. But the research that does exist is certainly promising, and the research on people with HIV and AIDS is strong and seems to have a very good effect. Now, one area where there is much stronger evidence is how supportive housing affects people's use of the healthcare system. This is very broadly findings, or the two things you find that how people use the healthcare system in supportive housing. They receive more outpatient services, appropriate services for their conditions, and they tend to reduce their use of inappropriate emergency care. But what's important about this is that many people think, well, therefore, supportive housing saves money. Emergency services tend to be more expensive than outpatient services. The problem is that depends on what the person's history of use of the healthcare system was. So for people that were using emergency care very frequently, long stays in inpatient hospitalization, frequent use of the emergency department, there may be pretty significant savings of cost savings there, and certainly much more appropriate treatment that they're receiving regular outpatient care for what was previously sending them to the emergency department regularly. But there's also the group, as I mentioned at the beginning, that may not really be receiving health services at all, even though they may have some pretty significant health issues. And so they might only see an increase in the use of the healthcare system. And so in the research, often, most research asks the question, does this save money? And not all research differentiates whether or not the people in the supportive housing, what group they were in, what their history of healthcare use was, and therefore what would you expect to see in their use of healthcare after entering supportive housing. That said, there are a few good studies, and this is probably one of the best, that find that by targeting the group that are high-cost users or frequent users of the healthcare system, large savings can be achieved. So this is a study out of Chicago. It's pretty well known, and it found that an average savings of about $6,000 per person per year were achieved through these reductions in days in hospital, emergency room visits, and days in a nursing home. What's important about this study is that the group that was served is very, very specific. They were recruited directly out of hospitals. They would have been homeless if not in hospital. And they were recruited mostly due to their physical illnesses. So they had high rates of liver disease, heart disease, HIV and AIDS, things that are very expensive to treat. They also tended to have high rates of mental illness or substance use disorders, but that wasn't the primary diagnosis for which they were recruited. And so this was a specific group and a very, very expensive group, and high cost savings were achieved. Now, that's not to say that we shouldn't serve a lower cost group. They certainly need supportive housing, but the cost savings that could be achieved would certainly be lower. So that's a quick overview of the evidence and how it affects health and health care. So what we know is that supportive housing is effective on multiple levels, at least. But what there simply is not enough supportive housing. There are many people in nursing homes, in institutions, and living on the streets that would probably be able to be successful in supportive housing but can't receive it. So the rest of this presentation we're going to talk about how to bring supportive housing to scale, our recommendations on how to increase the amount of supportive housing. In the paper that we wrote, we recommended 4 areas: expanding rental assistance, making greater use of Medicaid, reinvesting the savings to the extent that you achieve some savings in supportive housing, reinvesting those to create more supportive housing, and making sure that everyone in supportive housing actually needs the supportive housing, and we have some ways to do that. We're going to focus on the first 2 in this webinar. You can read the paper for the other 2. And I'm going to talk quickly about rental assistance. So as I said earlier, rental assistance is really necessary to keep supportive housing affordable. It's very rare that building units, even at the lowest cost possible, is affordable to the people that need supportive housing. There are a couple of models, and some groups have highlighted those, but it's extremely rare. Almost all needs rental assistance to fill the gap between the rent of the unit and the income of the tenants. But rental assistance generally, not only supportive housing, but in America generally, is extremely scarce. So only about 1 in 4 households eligible for federal rental assistance actually receives it. That includes everyone that needs supportive housing, but that also includes the much larger group of people that simply have low incomes and need help paying their rent. Now, up until recently, no one had attempted, and it was very difficult to get a sense of how much supportive housing we need. The data is still very sort of all over the place because we're talking about people both that are homeless, but also in the criminal justice system, also in the healthcare system. It's very hard to get a sense of the people that need supportive housing in all of those systems, and until now, we've had some good data on the homelessness system, but not much else. But CSH, the Corporation for Supportive Housing, just today actually tried this. They tried to look at all of these systems and get a sense of who in those systems needs supportive housing. And they came up with an estimate of about 1.2 million households need supportive housing nationally. You can play with their data at that link where they have state-by-state data, and you can look at the different systems they looked at. This is a first estimate. This data quality is still very difficult to use, but they did their best to try to use what we had to come up with something of a national estimate. So suffice it to say that the need is large, and it's certainly in the millions of households. So one key way that the center and a lot of my work tries to expand the supply of supportive housing is by expanding federally funded rental assistance, and to work with Congress to try to do so. So for those that haven't worked on housing a lot before, I'm just going to go through quickly the key programs that provide supportive housing and who's served by them. And these are the programs that if Congress were to expand, then we would be able to have more supportive housing. So housing choice vouchers, otherwise known as Section 8 vouchers, they serve 2.2 million households. They're the largest rental assistance program in the country by far. About 5 million households get federal rental assistance nationally, so almost half get vouchers. Vouchers are not targeted specifically on supportive housing, but they can be targeted locally, and there are a few special vouchers that do provide supportive housing. But you'll see they're the largest program, and they can be targeted, and healthcare providers can work with their local public housing agencies that administer vouchers to make sure that vouchers are providing supportive housing in their community. As I said, there are some targeted programs among vouchers. VASH is the largest that provides supportive housing for veterans, homeless veterans with disabilities. The services are provided through their VA. There are some others as well. There's some vouchers called non-elderly disabled vouchers that are in some communities that are specifically for non-elderly people with disabilities. But then there's some federal targeted programs. So these programs are targeted on specific populations. They don't always provide supportive housing, but often these are groups that need supportive housing. So there's a targeted program for homeless assistance, for people living with HIV and AIDS, for people with disabilities more generally, and for seniors. There's also some other non-targeted programs like public housing. But this is sort of the universe of the rental assistance available to create supportive housing. And I think the takeaway here is how much larger vouchers are compared to the rest of the program. So all of these programs could be very helpful, and Congress should certainly consider expanding them. But vouchers really is such a large slice of the pie that they could be particularly effective in expanding the supply of supportive housing nationally. But there's also state and local programs. They're a lot smaller, but many states have fund rental assistance. Sometimes often it's targeted specifically on supportive housing or on populations that often need supportive housing, like people with behavioral health issues, people experiencing homelessness, seniors. And so looking at what is happening funded by the state would also be very important in trying to expand those programs. So, if you're interested in getting involved and helping us make sure that these programs are as robustly funded as possible, please stay in touch with the housing team. But the other way to both help advocate for more rental assistance, but also to hopefully better use the rental assistance that's already available, is to build partnerships between the housing providers and service providers in a community. So PHAs are public housing agencies. They administer housing choice vouchers as well as public housing, and sometimes some other federal assistance as well. So they're usually the biggest rental assistance provider in a community, and often are quite willing to partner with service providers to help their most vulnerable households receive appropriate services. You can build partnerships with other housing providers that administer the other forms of federal rental assistance I mentioned. Continuums of care are the administer the McKinney-Vento homeless assistance. HOPWA, the housing for people living with HIV and AIDS, is often administered at the city level, though it sort of depends on the community. There's many different providers to partner with. And finally, as I said, there's a good amount of rental assistance funded in states, and so that doesn't mean that the state agencies are always talking. So making sure that the state housing and health agencies are actually collaborating in their state. So now I'm going to pass it on to Hannah Ketch to talk about how Medicaid can be an important resource for providing more supportive housing.
Thanks, Erin. I'm going to talk for just a minute about why Medicaid is relevant to the supportive housing conversation. So Medicaid provides access to medical care for low-income individuals and families. And although Medicaid benefits have traditionally covered clinical care, Medicaid programs and providers have increasingly been really paying attention to the non-medical needs that have enormous impact on people's health, including housing, in the vein that Erin was describing. So for example, a person who has diabetes and heart disease and also maybe has a substance use disorder is going to have a much more difficult time managing their conditions if they are also homeless. If that person can even get medication, they probably don't have a way to properly store it. They will be exposed to the elements and have a much higher risk of developing other health conditions, and they will have a much harder time participating in the healthy activities that could help them to improve their health. So Medicaid has a vested interest in helping people find and keep stable housing. And in some cases, housing becomes an effective medical intervention. Unlike affordable housing, anyone who is eligible for Medicaid can enroll and receive benefits, and the program's financing is mandatory and doesn't run out in the way that rental assistance does. And when Medicaid beneficiaries can't access affordable housing, that can quickly become a health issue. It's important to note that single adults who are experiencing homelessness are much more likely to be able to enroll in Medicaid in the 32 states that have chosen to expand programs. And one of the most effective ways to help this population to improve their health is to advocate for all states to fully expand their Medicaid programs. So what exactly can Medicaid provide? Medicaid does not pay for housing, but it does allow states to provide services to help people find or keep stable housing. Medicaid can also pay for institutional care like nursing facilities, as well as home and community-based services to help Medicaid beneficiaries stay out of nursing facilities wherever possible. And although there's been some confusion in states about what exactly Medicaid can pay for in terms of services, CMS released an informational bulletin basically just describing how Medicaid can provide services to people to help them stay in their homes or find stable housing. So that list of services Medicaid can provide includes transition-related services, so for example, housing search assistance, tenancy sustaining services, so case management or mediation, and also services to support collaboration across public agencies, the way that Erin was describing, and also with the private sector in order to assist states in identifying and securing housing options for individuals with disabilities, older adults who might need long-term services and supports, and also those experiencing chronic homelessness. In some cases, CMS has approved a few states' coverage of respite care through waivers. And since individuals in need of supportive housing often receive care from a range of medical and non-medical providers, it's particularly important for all the providers to communicate and integrate their services when possible. People talk a lot about coordination and integration of care, and that's particularly important between behavioral and physical health providers. That's often a really important first step. But medical providers and social service providers should also share information and communicate in order to just better coordinate the care that they're providing to prevent duplication and to make sure that their patients are getting the most efficient care. this kind of coordination and information sharing requires a huge amount of infrastructure that doesn't exist in most places. So most doctors don't know their patients' supportive housing providers and don't have a system to stay in touch with them if they do know them. And Medicaid can provide a foundation and an infrastructure for providers to work together to improve the health of their members, to create that system for communication. And in particular, Medicaid managed care plans are increasingly trying to figure out how to partner with the housing sector. And there is an enormous amount of potential for innovative partnerships between managed care plans and housers. I'm going to talk about a couple of examples of state Medicaid programs that are connecting these dots. So Tennessee, for example, has a Money Follows the Person program, which is a really good example of a state supporting Medicaid beneficiaries finding stable housing in the community. So what is Money Follows the Person? Many people in nursing facilities don't need the level of care that facilities provide, but they can't return to the community because they lack a home or the support they need to stay in their home. So this is the exact population that Erin was describing. Medicaid agencies in about 44 states participate in a program called Money Follows the Person, which provides state Medicaid agencies with funding and flexibility to help beneficiaries safely transition from a facility to their own home, the home of a caregiver, or to a community-based living situation, including supportive housing. The services provided under Money Follows the Person can include things like home-delivered meals, wheelchair ramps and other home modifications, and support for caregivers, so services that are not traditionally provided through Medicaid. And in Tennessee, the Money Follows the Person program partners with Medicaid managed care plans to provide most of these services. Health plan care managers develop care plans and help people transitioning out of nursing facilities arrange for those services that they will likely need to live safely in their community. And then once the beneficiary is in the community, the plan monitors the person's needs and care to ensure that that transition is successful. The services provided by Money Follows the Person can support individuals transitioning from a nursing facility into supportive housing. And so by paying for these services through Medicaid, the supportive housing provider may actually be able to invest more of their resources in their housing that Medicaid doesn't cover. So helping individuals live in the community also helps managed care plans and the state Medicaid agencies by preventing unnecessary health system costs. And the Money Follows the Person program has shown to be very cost effective. In Tennessee, between October 2011 and June 2013, more than 620 beneficiaries transitioned to the community through the program. Not only has this allowed people to live more independently in their communities, but it has also produced some significant state and federal cost savings, or at least cost avoidance, by reducing unnecessary nursing facility stays. Based on the state's estimates, it costs an average of nearly $2,000 per month to serve a Money Follows the Person beneficiary in the community, and this is compared to about $3,700 monthly to serve an individual in a nursing facility. So it's a little more than half to serve that person in the community. What we don't know here is how many of those individuals would have transitioned without the Money Follows the Person program, but it's likely that a number of those people would not have transitioned without these additional services. And the cost avoidance is really important for the program's sustainability because states frequently look at the cost-benefit analysis to determine whether to implement a program like this. Another state that has found some ways to support individuals in need of stable housing through their Medicaid program is Oregon. In 2012, Oregon created Coordinated Care Organizations, or CCOs, which are community-run partnerships among health plans, healthcare providers, and community organizations that are responsible for providing nearly all health services for their members. CCOs also have specific authority through the state's Medicaid waiver to provide what they call flexible services that improve beneficiary health, including housing-related services that are not traditional Medicaid services. CCOs are also working with supportive housing providers to cover many of the health-related services their Medicaid beneficiaries need. And CCOs have been broadly found to be very effective in helping members access health services. A recent evaluation found that CCOs have reduced members' use of the emergency room by 50% since 2011, while also increasing enrollment in patient-centered primary care homes, which coordinate beneficiaries' physical and behavioral health care. And that coordination may have resulted in some of those, the reduction in emergency room visits. So the CCO model is an example of how Medicaid plans and providers can partner to provide the kinds of services needed by many individuals in supportive housing. We've included here a list of resources that may be helpful if you're interested in more information on the subjects that we have briefly discussed here today. And we're happy to take your questions through the chat box on your screen, and you're also welcome to contact any of us directly. So I will hand it back to Judy.
Okay, thank you. So we have a few questions. I'm going to kind of shorten some of them and ask a few now, but we have time, and so ask some more questions. So I guess some of the questions seem to be coming really from both directions, health and housing, in terms of, what I think we've now calling connecting the dots. So how, if you were a housing advocate and you want to make the case in your state for both supportive housing and the services, how would you approach that? And then we have another question that really comes from the other way. If you're a health advocate, what's the biggest challenge in making this work? How do you work with your Medicaid agency and your housing people to get this going? How do people become providers, I think is how I would paraphrase the questions.
So I think on the housing side of things, we often, we talked about this earlier, we often highly suggest building partnerships, but especially just starting to talk to the healthcare providers in the community. It's clear that supportive housing can help meet some of the goals that they have for their clients, and they probably often do not know that what housing a houser might be providing, and more often than not, you serve the same people, and so I think that's especially important. I think one thing just to mention is that we've been recently digging in a little bit to the state-funded rental assistance programs, and many of those are oriented towards a population that in some way would have a budgetary effect on the state. I'm not sure how well those things are actually tracked, but often they're targeting population that's a high cost to the Medicaid program, and it's not clear that necessarily they're connecting the dots in the way that would be most effective and being able to track those costs, but they're certainly trying. So I think there's a pretty high likelihood that someone is trying this, and you have to find that person and try to bring them along.
Yeah, I think I would add too, from a housing perspective, we have to remember one of the points that Erin made earlier, that supportive housing, while it's been around a long time from the housing community, it's been seen largely as a housing stabilization intervention and not as a healthcare intervention. So as a houser, explaining to your health colleagues and partners in the community the illnesses that the people have that are that are living in your facility, in your buildings, so that they can see that you're serving the same population, and then talking about the case management that you're probably already providing, because that's a key piece that often isn't paid for in the healthcare system, or at least at the intensity that you're doing it, and that is a valuable tool to the healthcare system to help people not only stay in their housing, but you could also partner with the healthcare system to help people adhere to their healthcare advice and things that they need to maintain, to follow what their doctor is telling them to do. So thinking about the things that you do that could be a benefit to the healthcare system and communicating that is very valuable.
And what about on the healthcare side?
I think one of the best ways to sort of build momentum towards integration, which I think is what the question is really getting at, is exactly what Erin said. I think when a doctor and a managed care plan and a hospital administrator and housing providers, housing authorities, if they actually can get in the same room and talk about the people that they're serving and realize that not only are they serving the same populations, but that the services that each other is providing can be leveraged to make their own services more effective, I think that's really exciting to people. And so it's about how do you get that range of providers in the same room? And some states are actually investing in that. So there have been a couple of examples recently where state Medicaid waivers have included specific funding to essentially reward that spectrum of providers, give them funding to have those conversations about how to make their programs better integrated, how to make the systems work together more effectively in order to make the experience for the beneficiaries more seamless. So I think that just starting those conversations and where possible, putting money on the table to start those conversations is one of the best ways. I think frequently on the health side, we reach for the cost savings as a rationale for why we need to integrate. There are times, as Erin discussed, that there are real cost savings. But I think the danger of doing that is that we really limit the population that we can serve, as he was discussing. And so I think talking about the long-term investment of making good government, making these programs more efficient, and really trying to reach the providers who will be excited about it is the best first step.
So I think we have a question that sort of drills down on this a little more for you, Hannah, which is how do you get managed care organizations involved with these integration efforts? From someone in a state where integration is going on, but the managed care organizations aren't playing much of a role.
You know, and managed care organizations are, in most cases, private companies, and so they frequently want to know what's in it for them, which is a reasonable question. We could get far into the weeds of why the financing structure that most managed care plans are, work under currently is not usually very well suited to invest in these kinds of interventions. There are opportunities to change that financing structure and reward plans for investing in this kind of really innovative and important health intervention that will prevent costs down the road. If anyone is interested in having that super weedsy conversation, I am very happy to have it offline. But I think often the first step, again, is having that conversation with the plans. And they are looking for ways to better serve the homeless population. They know that this is one of their highest cost populations in a lot of cases. And so if they're able to partner with the organizations that can better serve this population and frequently make those services that this population is accessing appropriate and more efficient and effective, I think they often want to do that. So I think the first step is really just reaching out to them.
The other thing I would add is that as the integration efforts are happening, if you're advocating with your state, make sure that your state is thinking about this in the contracts that they're developing with managed care, so that now managed care really has to come and talk to us and partner with us, because now it's a requirement in what the state is requiring of them to do.
That's a great point. And there are actually some programs that have been developed, like, for example, the Health Homes program. Many states are using managed care plans to implement the Health Homes program, which is a care coordination program for particularly high-needs people. So that's an example of where the state has to partner with the local organizations that are working with the homeless population in order to be effective.
So we have one more question, but I just want to, as I've been listening, sort of say it sounds, as I said, this is our first Connecting the Dots webinar, and for some of these questions, I think, as Anna said, they are weedy. We can get weedy pretty quickly, but I think in order really to do this work well, you do have to get down into some of the operational details. So I think it would really be helpful for people that are on the webinar to provide feedback on, what are some of the topics that you would like to hear more about, and whether it's doing another webinar or thinking about the materials that we're producing. This is a new project, and I think we're really looking for you all to weigh in on how we can be more helpful. So we had a simple question and then another question. The simple question is where we can find the report that Erin talked about, and I thought we actually had that on a slide. So there you go.
It's at the Connecting the Dots website. It's the first thing at the top of it.
Okay, so you can find that and other materials on that website. And then we have another question that I think is for Erin, that I'll just sort of summarize into, well, what if people actually have vouchers and they have trouble finding housing? What can be done in that situation?
Yeah, I mean, this is an important question, especially with the group that we are working with, especially if they have a voucher or other forms of assistance. Even if the supportive housing provider doesn't do, say, credit checks or something, a landlord very well may. And so, or a landlord may simply not want to accept a voucher, and in most places they don't have to. So it's an important question. If you can't use the rental assistance, what's the use of it? So I have a couple of thoughts. The first is that in many communities, we found that providers providing intensive housing search services can be very effective. It can really help people find housing that they wouldn't be able to find on their own. It also helps the landlord get comfortable with helping this person find housing because they know they have someone to go to, someone to call. They know that the tenant they're leasing to understands their lease, that they've got someone checking on them. So having those services very early to help with the housing search itself can be very helpful. We've talked to one of the lead agency of the Continuum of Care in Los Angeles, who also happened to used to administer the Los Angeles voucher program, and Los Angeles has a lot of vouchers dedicated specifically to supportive housing and to people experiencing homelessness, and their success rate of getting people leased up on vouchers for the homeless vouchers is higher than their regular population because they provide those services for people experiencing homelessness that they don't provide to the general population. So in some communities that's possible. But there's other communities where the supply of housing, the simple number of units available is so low that it becomes difficult to use vouchers. And I think we didn't talk a lot about increasing the supply of housing, but in some communities that can be very useful, that we simply need more units to actually use the rental assistance in. So I also don't want to get a lot into the weeds of this, but I think there's good opportunities to talk to nonprofit developers who often have obligations to nonprofit developers that use federal development funds must accept vouchers and often want to. They're often mission driven. They're in the affordable housing space for a reason. They often want to help. And so talking to the developers that use low-income housing tax credits can be really effective in setting aside some units for supportive housing. But there's also opportunities to make that even more effective. In Pennsylvania, for instance, they actually mandate that I think it's 10% of their low-income housing tax credit units must be used for a very extremely low-income population. And so most of those units are filled for supportive housing because there's providers behind them ready to refer clients. So there's some, and that's on the state level where they are, how they administer the tax credits. So there's multiple levers to try to make sure that the housing that is being built is used to its greatest effect for supportive housing. So if you're in a community where you really need more supply, there's certainly options there to be able to partner with developers.
Okay, and just to clarify one thing you said, could you explain continuum of care when you said that? What you mean by that?
So the continuum of care they are a collaborative entity. So to receive McKinney-Vento homeless assistance, so the federally funded homeless assistance grants that provide permanent rental assistance for supportive housing. They also provide transitional housing and some more short-term rapid rehousing, short-term housing as well. For these homeless assistance grants, all the homeless service providers in the community have to put in one application collaboratively. And so that the entity that HUD has mandated is formed to put in that application is called the Continuum of Care. Now that's sort of a very wonky way of explaining it, but I think the takeaway is that the Continuum of Care, because of how the funding stream comes to communities, all the service providers, all the homeless service providers in the community have to collaborate. So there's almost always monthly meetings. There's usually at least a small, sometimes a very large nonprofit that coordinates all of that. So that's a really good entry point to find the supportive housing providers in your community, both on the housing and healthcare side. They certainly control some housing resources. They also often provide some supportive housing services that might not be currently part of the healthcare system. And so it's also an opportunity to try to make sure that Medicaid might be able to pay for some of the things they're already doing, so that's a door for an opening of a conversation. They also might have just a bunch of experience in providing supportive housing services that the healthcare providers might not have. And so the Continuum of Care could be a really good place to start some of these local conversations.
Okay, thank you. I think we're out of time, and thanks everyone for being on. As I said, we have recorded that, and if we just go right back for one more time to the contact information, contact any of the folks there with ideas, questions, things that would be helpful in your work, and any feedback on today's webinar as well. So thanks everybody, and we'll be back soon, we hope, with another exciting topic.